everybody. Welcome to the County Seat today. I'm your host, Chad Booth. Johnny breaks a finger, and you have to make a decision. Do we go to the doctor or not? Seems obvious, doesn't it? But when you live in rural Utah and you're a 2-hour drive away from any medical treatment, you think differently. That is the subject today, is the shortage of medical care in rural Utah, and we will start with the basics.
My dad was a country doctor who moved from a small Illinois town where he grew up to an even smaller one to practice medicine. It was hard work, but he loved it, and so did all my brothers and sisters. Growing up in a town of 800 people on a farm, we had horses, jeeps, motorcycles, room to run, and trees to climb. There was so much to do, we didn't have time to get in trouble. It paid off because 5 of my 6 brothers became rural doctors and surgeons themselves. And most of my sisters have made careers in rural medicine as well. So why is it so hard to get and keep rural doctors today? Well, here are 5 things to consider in the basics. 1, the very culture of rural communities tends to play down the advantages of rural life and instead focuses on the challenges. I'm sure you've heard it. I did. You don't want to stay here. There's no future. Go off to the city and find your fortune. And so kids do. Because we don't talk about the positive things that make us want to live rurally, our children place little value on the good things of rural life. In fact, rural communities often have better luck recruiting people from the city who want to escape the urban pressure they felt growing up. Number 2 is also cultural, but it is the one students discover in medical school. Most all schools tend to celebrate and elevate the specialty practice. It's like joining the ranks of the elite. Few medical school graduates find any prestige in family practice, and often they are lured or forced toward the higher earnings, not realizing that there are costs that go with it. Number 3, another obstacle to the hometown hero returning to set up a rural practice is the spouse factor. A student from Panguitch gets into a mentoring program at SUU, learns how to be a good medical student, crosses the hurdle into medical school, and comes out ready to practice. But in the 8 years of living in the city, they likely have gotten married and grown accustomed to the perks of the city life, while not having a clear idea of the blessings found in rural living. Nothing like an unhappy spouse to put the kibosh on plans for a rural practice, which is exactly what happened to my one brother who now practices in the big city. Number 4, another factor graduates face when seeking the practice of rural medicine is simply how to practice it. Doctoring in a small town is very different than in the big city, and they don't teach that in medical school. But the single biggest obstacle to retaining a rural doctor in Utah's remote communities is the debt. Currently, doctors entering a family practice for the first time are carrying an average of $300,000 of educational debt, limiting where a person can choose to practice medicine. When my dad graduated, his entire education cost $50,000, and the GI Bill paid all of it. This one fact alone explains why urban areas have about 90 doctors for every 100,000 patients, but in rural America, it barely tops 65. And specifically, there are communities right here in Utah where if you need to see a doctor, you have a 2-hour drive in front of you, not just a 2-hour wait. That means a lot of sick people don't get proper medical attention. To help staff rural clinics, there are state and federal programs which will agree to pay a significant part of a student's loan balance in exchange for a commitment to practice for at least 2 years in a rural setting. Generally, it amounts to about 20% of their student loans. It does not, however, help the practitioner understand the nuances of a rural practice. That's why there's an effort to also create mentoring programs to expose medical students early on to the unique nature of rural medicine. None of these programs will solve the shortage of rural practitioners overnight. But that is where our discussion will begin today when Chad comes back. For the County Seat, I'm Rhea Rossi Booth.
Let's be honest, you don't know much about Beaver County. Well, let me tell you about it. It's the birthplace of outlaw Butch Cassidy and inventor Philo T. Farnsworth. Some of the best skiing in Utah is at Eagle Point. You've got camping, Canyon Breeze Golf Course, Crusher and the Tushers, Beaver Territorial Courthouse, snowmobiling, renewable energy, Pioneer Car Show, Squeaky Cheese, Ghost Towns to explore, best water in the country, Paiute ATV trails, Old Frisco Kilns, horse races, hunting, fishing, and it's a good place to live. Beaver County, mountains of fun. I could tell you more, but why don't you come and see it for yourself?
149 million years in the making. Dinosaurs once roamed this land. Now they're found at the Dinosaur National Monument. Let's take you beyond the bones. We call it Dinosaur Land. You'll find it offers adventures and sights not seen anywhere else in the world. Come to Dinosaur Land, Vernal, Utah. You'll want to stay forever. The dinosaurs did.
The Utah Farm Bureau began as a collection of farmers supporting each other to raise the food we enjoy. Today, Farm Bureau membership encompasses everyone, whether ranchers, growers, or just everyday folks like you and me. Members enjoy discounts on items like vehicles and ATVs, or insurance that's very affordable. You don't have to be a farmer to join, and dues are small, but together we make a big difference in keeping our food supply local and abundant. Join Utah Farm Bureau.
Welcome back to the county seat. We are talking today about the challenges of rural medicine, shortage of doctors, and what we can do about it. The discussion today is about the what we can do about it and what we are doing about it. Joining us for our conversation is somebody who certainly should know if the programs are working, Rebecca Powell, who is a senior medical student at the University of Utah School of Medicine. And we also have the dean of the School of Medicine, the interim dean, and Wayne Samuelson. There are basically 3 or 4 programs that are in place right now to try and steer students rurally to a medical practice and then back to a rural community. And I guess you've been involved in 3 of them.
I've been involved in, yes.
So tell me a little bit about it.
So in my college years, I went to Southern Utah University. I'm originally from Utah, a little town called Ivins outside of St. George, for those who are familiar with Washington County. And I went to Southern Utah University, and there they have a program called the Rural Health Scholars Program. This program is a framework for undergraduate students who want to pursue graduate health-related education, whether it be dental school, optometry school, nursing, and in my case, medical school, to become a physician. And so that's what I joined. And being at Southern Utah University, which is a regional school in Southern Utah, a lot of my volunteer experience was in communities even smaller than where I grew up. So that's an example of an opportunity I had through Rural Health Scholars during college. My goal my number 1 choice was to come to University of Utah Medical School for my medical degree. I was accepted, and I was happy to.
Achieved it.
I have achieved it. A few months away from graduating. I graduate in May after 4 years at the school. And one of my goals once I was there was to make sure I could maximize my time in rural settings, to maximize my learning and maximize just what I want to do, which is eventually a rural practice for myself. And so one of those ways I did that is during my 3rd year of medical school, when we start what are called our clinicals. They take us from the classroom, and now they start rotating us through the different departments of the hospital. During my family medicine rotation, I actually requested to go to Blanding, Utah.
And this is a program that UMed is involved in, is getting students specifically into rural settings in the rotations as part of their practicum, so to speak.
Yeah, that's correct. The family medicine rotation is where most of that takes place now, and one of the things that we're working on is trying to broaden that experience to more communities in other primary care specialties. So not just family medicine, but also in internal medicine, pediatrics, wherever we can find spots for them to have that experience in an underserved and or rural community.
Is this really working to solve that rift of people going to medical school and ending up practicing in a rural community?
Well, we think it's a start, but it's only a start. And one of the good things about the Rural Health Scholars Program at SUU is that it recognizes that there is more than just physician care that's important to rural and underserved areas. And so that experience prepares students for a wide variety of positions in healthcare, not just to be physicians, but also to practice in other ancillary areas. And some people start in that program thinking they want to become a physician and decide that they want to be something else, which is also very valuable. But Cedar City is not the only part of Utah where we could, make some inroads. And so we are actively seeking now to bring physicians or hospital administrators or people from other parts of the state into participation on our admissions committee to help us identify students in different parts of the state who really belong in medical school and have them participate in the decision.
How young can you start figuring that out? I mean, do you start that at a high school level? Do you start at a college level?
One of the organizations I belong to as a medical student at the University of Utah is called UROP, and that stands for Utah Rural Outreach Program. And what that organization does is it organizes medical students, generally first and second years, who have the time in between their courses to go during their winter and spring breaks, and they actually travel to rural high schools in Utah. And they talk about not just medical school, but just any sort of medical training beyond high school. Talking to these kids who maybe you've never considered, like I'm going to be the first student in my family to graduate high school, never even considered college. But if I want to be a physician or if I want to be a nurse, I'm going to have to go to college.
A lot of our students participate in programs where they tutor, we call these pipeline programs. They tutor in the underserved and underdeveloped schools in the Salt Lake area and beyond. The idea being that you really can't compete to go to medical school unless you can do well in college. You can't perform well in college unless you have some basic skills that get you through high school.
Right.
And a lot of young people, don't dare to dream that they could do this.
Historically, do you think there has been, or is there any anecdotal evidence of this actually working, where if you're pulling people from Ivans and pulling them into a program, that they are more likely to actually return to a rural practice, even after the lure of the spouse effect and all the glitter and glamour of specialty practice and all that?
There appear to be a couple of influences on the eventual choice for physicians where they want to live and work. A big drive is where you actually did your residency program. And so residency is what you do after medical school that actually, we call it training, that's what gets you your license. We get the degree here, but they all have to go on and train in some specialty, usually for a period of 3 to 5 to 7 years. That's a big draw where you finish that up because you've been working with physicians in that community, in that area, and they tend to, like you and offer you positions.
The thought that came to my head in this conversation, and you both are more than welcome to answer it, is that this is all well and good, but how many residencies can you do at Panguitch Hospital?
Yeah, well, that's just exactly the point. You can't. Okay, and Utah has a shortage of residencies, and as we bring more and more young people into medical school, we're pretty much guaranteeing that they're all going to leave and not come back unless we give them a reason to come back. We're not going to be able to get the number of residencies in Utah, and certainly not one in Panguitch, just for population reasons, that will leave those graduates wanting to stay there. So we have to create other reasons for them to come back to Utah, and that's what we're trying to do.
And the way we do that is, during my education, my 4 years of medical school education, there's certain rotations that are set. I will rotate through surgery. I will rotate through family medicine. I will rotate through pediatrics. So then I can decide, can I see myself as a pediatrician? Can I see myself as a surgeon? But then there's another question. Can you see yourself as a rural physician? And if you've never had any experience as a rural physician, having preceptors or making those connections or actually being there on the ground, boots on the ground, learning from those practitioners, how can you ever comfortably say this is somewhere I want to go?
And that's really it. Now, one of the attractions of practicing medicine in an urban center is you have access to ancillary help. Your pharmacist, your dietitian, your physical therapist, your occupational therapist. These are people that are just down the hall. That's not always the case in an underserved area. So another big part of our initiative is creating the same sort of training opportunities or learning opportunities for students in the other health professions.
I know that there's a reimbursement program that's, I believe, state, federal, and the hospitals chip in, that'll pay like $60,000 for a 2-year contract to go back and spend 2 years filling that gap rurally. So if you go and you fill that gap, I mean, how much culture shock is there at the end without some of these other trainings to get them to think about
Well, there's a lot. You need more than just forcing people back with the incentive of getting your debts paid because they just start the clock. What we're hoping to do is create relationships, good feeling, and hopefully bring the other healthcare professions along with us, so someone can go and practice in a rural community or an underserved community and feel like they are practicing state-of-the-art medicine with colleagues who will help them do that, delivering care to a community that's very appreciative. And the impact of that is, that's a great place I want to live. I want my family to come here. I want to stay there. That's what we're hoping for. We've seen it work in other states.
Do the communities need to pay more attention to the young kids that are coming through on their rotations?
You know, I think they really try. One of the problems is that we at the medical school have not facilitated that. We're trying to change that right now. Yeah. You know, working more with the communities and, like I say, getting the right students into medical school. That's why we are, actively soliciting people from the communities where we're trying to put students to participate with the medical admissions committee. And Dr. Chan has been very, very, inviting and worked really hard to get those kind of people in. It makes the meetings difficult because you have to do some people on Skype or on teleconference, but he's done that. And I think the committee, the admissions process, and the school are all benefiting from that.
I would imagine that if you were in Fillmore and somebody brought you lots of cookies while you're on a rotation, you probably could be tempted to say this is not a bad gig.
Well, anecdotally, I worked very hard while I was down in Blanding on my family medicine rotation, not only because I wanted to learn, but because I wanted to prove myself on that rotation, because it was something I was looking at doing. And they said, as I left, we love you, and if someday you want to return to our community, we would love to have you in whatever capacity it is, because at that time I hadn't decided on my program of choice yet, whether it be family medicine or pediatrics or the combined program, which I ultimately settled on. And along those lines, just like most people, their favorite genre of music is whatever they had when they were a teenager during those formative years when you're growing up and learning who you are. I feel like during my formative years of my medical training, which is during medical school, and prior to that in college, I definitely was influenced by those people who had a passion for rural medicine, and that was instilled in me, and I'm going to continue that forward because I'm going to be very happy with it.
My own anecdote I told you about as a subspecialist, moonlighting in an emergency room one weekend a month in a very small rural community. Now, at the end of that time, when I was finished my fellowship and I had accepted a faculty position at Duke University, so my dream of dreams, the academic physician, research, everything else, the people in that community gave me a going away party. And they said, if you ever change your mind about being a specialist and want to come back here and be our internist, we would love to have you. And that was a very, very tough decision to make. If you've ever seen the movie The Color Purple, it was filmed in that town.
Oh, wow.
And they didn't change anything for the movie. It was really a very small, underserved community that really struggled in a lot of ways, but beautiful, wonderful people. And they even touched the heart of a hardcore subspecialist like myself.
Well, thank you both so much for being part of this conversation. When we come back, we'll take a look at a doctor that's starting a program that's called Direct Care that actually fits a model of filling in the gaps in some of these small rural communities. We'll be right back with County Seat.
There's a little place on a Utah map where I was raised, where my heart's at, where the sagebrush grows wild and high, and the stars come out at night. Oh, there ain't nothing like being raised in the basin with a Ute reservation, skiing starvation, that Duchesne County life.
The Layton Hills Mall offers more than just shopping. Bring the whole family and enjoy SeaQuest Interactive Aquarium to feed the fish and exotic birds, hold live reptiles, and even swim with the stingrays. Or pump up the action and visit Dartside, Utah's premier soft foam dart tag arena. And don't forget the Great Room Escape, where you can challenge your friends to solving mysteries inside themed rooms. So come and experience great fun at the Layton Hills Mall and visit playindavis.com for other great activities.
All local products have a story of magical places, real people, and delicious recipes spanning generations. So go ahead and discover flavors you've never tasted and friends you never knew you had. Utah's own. Discover local food.
Welcome back to the county seat. As we are looking at the problem of rural health care, we will have to look outside the box because we haven't found any answers inside the box. We recently had an opportunity to interview a doctor in Kansas City who has thought the entire practice of medicine outside the box, and it's working for him. He believes it will work for rural medicine as well.
Look at your eyelids.
If it takes 11 years to train someone to do something and 2 years to make them quit, you can't keep up with that. There's no system that can keep up with that kind of mass exodus. The previous mentality of physicians was, medicine was everything, and nothing else superseded that.
We like to say, in a lot of ways, we haven't changed anything. The practice of family medicine is the same, but in other ways, we've changed everything by changing the business model. We're an insurance-free practice that charges a monthly membership for full access to care. But by doing that, we remove 90% of the headache, the hassle, the inefficiency, so that the patients now can get quality, affordable care. The doctors can focus on the patients, provide procedures and medicines and lab tests at a discount to really make medicine affordable and accessible again. What we gain in efficiency, we also gain in profit. By being able to cut 90% of our overhead, we can charge the patients a fair amount and still retain more of that. Our doctors on average make 30% more than the local family physicians in this area. So it's actually more profitable for a doctor to be in this model, providing very affordable, very accessible care. And I think that's what business does well, find competing things that don't make sense, but we get a better, faster, cheaper product that's a higher quality through good business in all sorts of areas of our lives.
Yeah, I can't imagine, going back to seeing more patients a day than you're able. Yeah, it's akin to making a mechanic fix 10 too many cars per day. Somebody's going to get in a wreck. I mean, that's what it is in medicine. You can only truly take care of so many people a day, and if you do more than that, then some of those people aren't getting the care.
If it's bad for the patients, it's bad for the doctors, and that's what's driving doctors away from rural medicine. They feel like they need to be part of a giant system to play this giant paperwork game. This model, streamlining that whole process, I think that we've tried to do higher and higher volumes, and we've gotten less and less value in return. The standard doctor would have 3,000 patients and see 30 or 40 a day. In our model, the doctors are limited to about 600 patients and see 5 or 6 a day, so that we can do same-day appointments almost all the time. We can do hour-long appointments if need be, but we can also be available for phone, text, email to make healthcare accessible without the patient needing to come to the office. We have more time to focus on the patient, so I'd like to think we make fewer mistakes. We have less paperwork, less distraction. Depending on the study, you can look at a doctor spending between 22 and 65% of their day on the computer doing paperwork or electronic filing. That's just a whole chunk of time the doctor isn't focusing on the patient.
I certainly enjoy this a lot better than what the alternative is. We even have people in residencies or graduating medical students, and they spend time with us and they say, do I really have to do 3 years of like an insurance type practice, learning that?
The rural doc has patients who need care. I grew up in a town of 900 myself. One doctor could manage that whole town very well in a direct care model. Just with a simple redesign, same medicines, same labs, same doctors, different payment model to make these things fit.
This gives you a lot to think about, doesn't it? Let's take stock of the things we've covered. We identified the problems in the beginning of the show and the basics about what the shortages were caused by in medicine. We've looked at the things that the schools have done to improve it, and government as far as the subsidies and programs. And we've looked at one doctor who's thought outside the box and come up with a different way to approach medicine that might work in rural Utah. Sounds promising. But there's still other things that we may want to consider, and we'll get to that in my 2 cents worth in just a minute.
look south to adventure. Look south to beauty. Look south to San Juan County. Out here, the road goes on forever, and what you'll find will change how you see the world. Climb on your OHV and discover forgotten landscapes and vistas that challenge the imagination. From Blanding and Monticello to the cliff faces of Monument Valley, we're open and ready for you to explore. San Juan County, Utah's Canyon Country.
In a place that is beyond words, there is nothing to be said, except take your time in Bryce Canyon Country.
Welcome back to the county seat. We have looked at the issues of shortage of medical care in rural Utah today. Here's my 2 cents worth on that subject. The sad truth is that we have allowed medical culture to cost too much to work in a dispersed population base. It costs too much to get an education. You have to do too much to avoid being sued. Our culture makes you need too much because success is measured by how much you make, not by how well you serve. And finally, we as consumers expect too much of the insurance medical complex and no longer ask how much we're being charged for a drug or a service. Yet, we are still paying for it in our premiums and taxes. You know, I once asked my doctor how much it would cost to get a procedure done that he was recommending. He couldn't answer the question. By removing that direct link between doctor and patient as to the cost of treatment, it becomes far too easy for prices to skyrocket because the person paying premiums, as well as the doctor prescribing, are disconnected from knowing the cost of treatment. We have to move back to a place where patient and doctor are aware of and talking about how much care costs. I believe that that awareness, along with the things we talked about today, will start to bring things back in line again and provide the long-term fix to access to care. Thanks for watching today. You can see the extended discussion with our guests on our YouTube channel, along with the full interview with Dr. Umber. We invite you to follow our social media for midweek updates, and we will see you next week on the County Seat.